have your attention, please? Have your attention, thanks. Thank you. We might as well get started. Tonight it's my pleasure to introduce our guest speaker, Dr. Robery Hirsch. Rob's been a periodontist since 1976. He's had a long association with the periodontal education of dentists, periodontal graduate students, dental hygienists and oral health practitioners through the University of Adelaide. He has a PhD in pathology and has published over 40 papers in referee journals. Currently, Robert's been up here for the last 4 weeks helping us supervise our dental students, particularly in the area of periodontics. I think we're very fortunate tonight to have someone of Dr. Hirsch's calibre speaking to us. It just happened to occur that way. So please make him welcome as I introduce Dr. Robery Hirsch.
Okay, thanks very much. Good evening, colleagues. It's terrific to see so many of you here tonight. Cairns is a beautiful part of the world, as you all know, and as I and my wife are coming to know. And it's clear that it's having a resurgence in the tourist industry, because there was no hire car left, and the only one that was available for us was this. So we accepted it with gratitude, but we're not quite sure why it had a potbelly stove in this. Okay, yeah. Yes. Okay, so tonight I want to put modern-day periodontics into a little bit of perspective, and then move into examining the possible role of this relatively new drug called Azithromycin in the management of severe inflammatory periodontal diseases. So if I don't want to really go through this chart in great detail, but the periodontics sort of crawled out of the primordial slime of plaque around the 1970s and 80s, and around that time it was first recognised that people had different susceptibilities to periodontitis. So you could have all the plaque around your mouth in the world, and most people just had a pretty bad dose of gingivitis, but they didn't go on to destruction of the alveolar bone and tooth loss, except in a small minority of people, probably about 7 to 10% of a given population. Smoking as a risk factor for this susceptibility wasn't really recognised until the 1990s, relatively late, I think. And out of that we developed periodontals and periodontopathogenists and periodontal medicine, so the interrelationship between advanced periodontitis and systemic diseases such as heart disease, so forth, strokes. I'll just put M to gain, M to no gain. Some people call it M to no gain. But now in the 2000s we're in this era of post-modulation. We're recognising through our understanding of periodontal pathogenesis that it's possible to manipulate the host and get a better outcome periodontally than with your conventional scaling and cleaning, debridement, root planing, whatever you want to call it, and periodontal surgery and so forth. So this is really where periodontics is at the moment in terms of the current research. So host modulation, we do that in various ways. We do it by encouraging our patients to stop smoking, because smoking has this very powerful effect on the periodontal tissues. The number one risk factor for periodontitis, as far as we know at this point in time. Other things that we look at are diabetes control. If someone's got poorly controlled diabetes, we want to do something about that. Stress management, we're probably not very well equipped to deal with that, but that's probably an important part of it. Some people are looking at micronutrition and these other types of approaches, including fish oil, which is a very strong anti-inflammatory agent in itself, and krill oil and so forth. So there was some research going on in Adelaide looking at fish oils. In the US, there's a drug called Periodontal, which is a low-dose doxycycline, which is used routinely by periodontists as an adjunct to the treatment of severe periodontitis. And this is not based on its antimicrobial properties, rather its ability to as an anti-collagenase agent. So we know that collagenase is one of these products that the host produces that breaks down the periodontal tissues. And Periodontal has been shown to be relatively successful in helping slow down periodontitis. The downside to that is people need to take it for months, so they're on 1 or 2 tablets a day for months to years, and it's also not available in Australia. You can't prescribe it for use in perio. And so this then takes me to the topic of tonight's presentation, which is the antibiotic called Azithromycin. It's a macrolide antibiotic. It was invented in, I think, around 1980 in Serbia, then Yugoslavia, and it was introduced in the United States in about 1990 and wasn't available in Australia until 2004. It's the 12th most commonly prescribed antibiotic in the United States at the moment, and it has a wide range of uses, some of which I'll mention a bit later. So why would we be interested in this drug in periodontal therapy? Well, it happens to have a split personality, and it's a very good antibiotic. So it targets gram-negative bacteria and a whole other range of bacteria, and it does that very effectively. And on the other side of it's not really its darker side, probably its more interesting side from a perio point of view, is that it has immune modulating properties which are quite separate from its antibiotic properties. Now, it's quite difficult for us as dentists sometimes to get our heads around the fact that antibiotics can have these dual roles. So you really need to think of this drug as, having very good antibiotic functions, but on the other hand, altering the immune system in probably a very beneficial way in terms of the management of periodontal diseases. It's very rapidly absorbed after a single dose, so 2 to 3 hours. It zooms out into the tissues from the plasma, and once in the tissues, it has a very prolonged retention time. Of greater interest periodontally is that it accumulates at sites of inflammation. So it seems to target into areas where there's a lot of inflammatory response. And in those areas, it's loaded up into polymorphs, so neutrophils, macrophages, and fibroblasts. And so in the periodontal setting, that's really just where we would need a drug. So it's right there, we need it. Furthermore, if I orientate you here, where the red represents the tooth surface, and we've got biofilm growing on the tooth surface, and here in the biofilm we have our periodontopathogens, so our Porphyromonas gingivalis, and our AA, so forth, and a whole lot of other bacteria, which we don't really need to know that much about in terms of their names at the moment. So we know that in normal function, the neutrophils coat the biofilm. So the neutrophils come out of the gingival connective tissues in very large numbers. Probably someone with periodontitis loses a lot of neutrophils from their circulation. through the periodontal tissues as they go to sort of wall off the biofilm. So that's called palisading. So these neutrophils are loaded with azithromycin, and as the neutrophils break down, the azithromycin is able to penetrate the biofilm. And this has been shown in numerous studies now, and it's very different to a lot of other antibiotics which are not able to penetrate the biofilm. That's why we're concerned about biofilm and its ability to resist antibiotics in the past. So the next wave of neutrophils comes in straight away, and we know that azithromycin is present in neutrophils for at least 28 days after a single dose of the drug. And we don't know actually how long it persists. Well, actually, it doesn't persist in neutrophils because they're quite short-lived cells, but it must persist in precursor cells in the bone marrow. So it's still present after 28 days in this was a volunteer study of people who were completely healthy. They were given some azithromycin, and the study went for 28 days to see how long it persisted in their neutrophils. So it could actually last quite a lot longer. The other side of the azithromycin story is its take-up by macrophages. Now, macrophages are cells that orchestrate, and they're the ones really that determine whether a person is going to get periodontitis or not. So they're sitting in the periodontal tissues, and they're emitting a whole lot of different cytokines or chemical messengers to instruct other cells around them what's going on. So if there's a lot of plaque biofilm products coming into the tissues, they will be putting out inflammatory mediators which switch on the inflammatory response. They're really the cells that control everything. So in terms of what azithromycin does to macrophages, we know that macrophages take up the azithromycin very readily, but when they're in the macrophages, they result in a decrease in these type of cytokines, which are the pro-inflammatory cytokines, and these cytokines increase, and they're the anti-inflammatory cytokines. So macrophages are capable of producing both pro and anti-inflammatory cytokines. The net result of that is that there's decreased inflammation. The other part of the story is that fibroblasts are also loaded with azithromycin, and it's thought that they could act as a reservoir for continuously feeding neutrophils and macrophages. And it might be the mechanism whereby azithromycin switches on healing of the periodontal tissues, which I'll demonstrate with a few case reports shortly. All right, so to summarise, we know that periodontitis is triggered by macrophages just going berserk and producing a whole lot of pro-inflammatory cytokines out of the tissues. As a result of that, there's a lot of inflammation comes in, and then we get periodontitis as a result of that. What azithromycin seems to do is switch whatever this mechanism is off. It reduces inflammation, and it seems to have an extra property of stimulating periodontal healing. So it's sort of like a magic bullet, if you like, where it has these three properties. And it might not be completely coincidental that in a course of azithromycin, people only have to take 3 tablets, 3 500 milligram tablets, one a day for 3 days. And that's very different to the normal dosing schedules that we use for Amoxil or Flagyl or whatever. So in one corner here we have its antibiotic action. Another tablet is, anti-inflammatory, and another tablet promotes healing. Now, obviously, that's very facile, but within that course of azithromycin, this seems to be what happens in the periodontal tissues, and that's very different to any other antibiotic or any other agent that we've been able to use in Australia. Very different. Okay, so there's three tablets in the course. The prescription is generally for the generic version of azithromycin. It's called Z-E-D-D, and so it's Z 500 milligrams, 3 tablets, 1 tablet a day, and you'd usually give it 1 to 2 hours after a meal. And generally that cost is about $15. So it's not on the PBS. If some pharmacists want to charge $60 or $70 for it, then they're charging too much, but it should be about $15. Now, the side effects were considered to be low until May 2012, and I'm going to get into that in a minute. And generally, you find that about 5% have a mild gastrointestinal upset after taking azithromycin. That's very different from its cousin erythromycin, which used to be quite nasty to take, and a lot of people would have side effects from that. But generally, so as I said, it's the 12th most commonly prescribed antibiotic in the state, so millions of doses are given out each year in the US. Because of its, the patients only have to take 3 tablets, there's very good compliance. And generally, most people don't have any side effects from it. Okay, now the flying in the azithromycin ointment came in a paper in the New England Journal of Medicine in just a couple of months ago. And this was a retrospective study of people in the US who had been prescribed